Good morning, good afternoon, and good evening, depending on where you're joining us from today. I would like to welcome you to CCE's Network Dialogue, focused on the role of patient navigation in achieving cervical cancer elimination. My name is Alex Wright. I am the Head of Global Policy at Programmes at Cancer Research UK and the co-chair of Cervical Cancer Action for Elimination, along with my colleagues from the American Cancer Society. For those that aren't familiar with CCAE, we have a long history in supporting organisations and individuals working within cervical cancer elimination. We're now on our third year of our virtual dialogue series, and these dialogues are opportunities for organisations and individuals to meet and to engage in critical conversations around cervical cancer with their peers from around the world. And this is our second of 4 dialogues planned for this year. And you can see the upcoming topics for the remainder of this year on this slide. We've also held a variety of dialogues on a range of topics related to cervical cancer thus far, as you can see on this slide. And if you've missed any of the previous dialogues, you can review the summary reports for key takeaways, and the links will be shared in the chat. So before we get started properly, just a few housekeeping items, if I may. We would love it if you could take a moment to rename yourself in Zoom if your name isn't currently showing. And there are 2 ways to do this, as shown on this slide. You can open the participant list, click More next to your name, and then select Rename. Or you can right-click on the video tile and choose Rename. Please rename yourself if you can with your name and your organisation where that's applicable. Thank you very much. It makes life easier for us in the chat. And speaking of that, we would also really appreciate your active engagement in this dialogue. And I know our speakers would love to hear your thoughts, comments, and questions. And there are a couple of ways in which you can participate. Firstly, you could use the Q&A feature to add questions for the presenters or colleagues and peers during this dialogue. You can add your comments and experiences in the chat. And when you do, please start by sharing your name, organisation, and country in the chat box. And finally, note that we will record this session and share it with you by email afterwards as well. So thank you for your patience going through the housekeeping items. And let's get to our agenda for today. As we work toward the WHO cervical cancer elimination targets, 90% of girls fully vaccinated against HPV by age 15, 70% of women screened with a high performance test by 35, and again by age 45, and 90% of women identify with cervical pre-cancer and cancer receiving treatments. We're increasingly recognizing that even the best designed life-saving programs fall short if people are unable to access them or move from one point of care to the next. Success depends not only on having services available, but ensuring that people are supported in accessing them and completing the care they need across the cancer prevention and care continuum. And while it may be known in different names and different settings, whether it's patient navigation, community navigation, care coordination, or patient support, the underlying goal is the same: helping people overcome barriers and connect to the services that they need. And patient navigation has emerged as a critical strategy for bridging the access gaps, helping individuals access services, overcome barriers, and remain engaged in care from prevention and screening through diagnosis, treatment, and survivorship. And today, I'm pleased to welcome 5 leaders and leading practitioners from diverse perspectives and settings around the world. They join us from the Global Alliance for Cancer Patient Navigation, a community navigation program in India, an oncology navigation program in Egypt, and a clinical and resource navigation program in Nigeria. And last but by no means least, the American Cancer Society's Patient Navigation Resource Program, Beacon. Each presenter will share their experience and insights on how they're addressing the cancer prevention and care continuum and adapting approaches to meet their local needs and challenges. Without further ado, I will introduce our first speaker today, Christy McCumb. In the interest of time, I'll be using a short introduction for each presenter, but full biographies will be shared in the chat. If you're not presenting, me grateful if you could put yourself on mute. Thank you. Christy is a public health leader with 25 years of experience expanding access to services for underserved populations, both in the US and globally, and she leads global navigation initiatives for the American Cancer Society's Global Cancer Support Team. Over to you.
Thanks, Alex. Well, hi, everybody. So happy that you're here today with us. Looking forward to the conversation later on today. As we know, or as we will discover, patient navigation plays a really important role in improving equitable access to high quality cancer care. And we have this great opportunity to integrate it more fully as a powerful tool to achieve the goal of ending cervical cancer. So you're going to hear some real world examples, but before we get started, before we do that, let's make sure that we have kind of a common understanding of the key concepts tied to navigation. So cancer care is a complex situation for anyone, but the challenges are often even greater in low and middle income countries. As I know many of you know from personal experience, limited healthcare resources, higher levels of poverty, and health systems that have been historically focused on infectious diseases can make it very difficult for individuals to access and navigate cancer care. So as a result, many people lack access to information on cancer signs and symptoms. They miss preventive services. They are diagnosed at late stages when treatment is more difficult. They may have limited access to treatment or pain relief in the first place, and they receive insufficient psychosocial and practical support. And we refer to these gaps as leaks in the pipeline because they prevent individuals from receiving the care that they need, contributing to avoidable suffering and poor outcomes. So let's imagine Mariam, a 35-year-old woman from a rural community. For years, she has lived with persistent pain, assuming that it was simply fatigue. Then a community health worker explains that it could be a symptom of cervical cancer and encourages her to get screened. Mariam follows through and she learns that she has invasive cervical cancer. So as you think about Mariam's journey, consider the challenges that she and her family now face. How will they navigate multiple providers, understand complex medical instructions, afford treatment, arrange travel and lodging, and care for their children, while also managing all the emotions that come with a cancer diagnosis? At how many points along the way might uncertainty, financial barriers, or lack of support delay care or cause Mariam to stop treatment altogether? So, as we've seen, or again, know from personal experiences, there are many ways a person like Mariam can fall through the cracks and run the risk of not surviving her cancer. But we have a means to make that care pathway easier for people, and it's called patient navigation. And this is the kind of official definition. Patient navigation in the cancer care setting is defined as individualized assistance offered to patients, families, and caregivers to help overcome healthcare system barriers and to facilitate timely access to quality health and psychosocial care from pre-diagnosis through all phases of the cancer experience. And even though we use the term patient here, navigation covers all of the cancer experience, so that even those who are not yet patients or do not become patients can benefit from navigation. And again, what are we solving for with navigation? Well, we're talking about barriers to care. A barrier to care is any factor that delays or prevents an individual from accessing appropriate and needed care in a timely fashion. And there are many different types of barriers, as you see here on the right-hand side of the screen. And additionally, these different types of barriers will often stack on top of one another, and they most affect those who are already disadvantaged. So next slide, please. Again, though patient navigation was initially developed and is most well known for supporting people during the diagnostic and treatment phases of the cancer care journey, it is applicable and even more helpful for reducing barriers to care when applied across the continuum. And when it comes to cervical cancer elimination, we have clear opportunities to offer navigation services earlier in the continuum to help women more easily access vaccination and timely screening. And this looks like educating women, assessing individual barriers, impeding action, and helping them systematically overcome those emotional, logistical, and resource obstacles. So, given that patients can face barriers at home, in their communities, on the way to seeking services, and even as they are receiving services, different types of navigation can address these different challenges. Clinical navigation helps patients overcome health literacy, communication, and psychosocial barriers. Resource or non-clinical navigation addresses logistical, financial, and other resource-related barriers. And physical navigation addresses mobility, language and literacy barriers, particularly within a facility, imagining someone traveling somewhere and not speaking the language of where they're receiving care. It's typically carried out by individuals or teams of individuals who are typically called patient navigators, though there are many different types of patient navigators. And they may also be known as care coordinators, community health workers, social work navigators, lay health advisors. There's a lot of names, but the key thing to remember is that navigation, it's really about the role that they're performing and the services that they're providing. So anticipating and assessing patients' care, identifying resources, and co-developing action plans with the individual or family to address the identified barriers, and also partnering with community service providers to expand the amount of resources available to the individuals, and helping to facilitate patient and provider communication. So this work, again, is done to remove barriers and ensure timely diagnosis, delivery, and access to services with that end goal to end suffering from cancer. Okay, and then Dr. Harold Freeman is the founding father of patient navigation, and he was the first to demonstrate its effectiveness in reducing disparities in cancer outcomes. And he likens it to a relay race where the patient is the baton. So really, navigation is not the responsibility of a single person, but a coordinated team effort that supports the patient through that cancer journey. So again, the patient is the baton, the runners are the navigators or the people who are performing navigation duties, and each is supporting a patient at a different stage of care, which again can start from the community into the health facility setting or within the health facility setting. And the handoffs are critical. Just as relay races can be lost during a poor baton exchange, patients can fall through the cracks when communication and coordination between providers and navigators is inadequate. Next slide, please. So just to say, without going into a lot of details, we have 30 years of research that has documented that patient navigation overcomes barriers to care and increases access to timely and appropriate cancer care. It's a proven intervention to reduce cancer disparities and advance health equity. And it's one of the reasons why we at the American Cancer Society continue to invest in efforts to make patient navigation a standard of cancer care around the world. And I want to briefly introduce some of those efforts. Next slide, please. So over the last 10 years, we've been steadily adapting and applying our learning of patient navigation from the US context to other settings around the world, with significant efforts made to advance patient navigation in LMICs. And with our partners, we've been able to collectively demonstrate the relevance and effectiveness of navigation in a variety of LMIC settings, which has given us motivation, again, to push for navigation to become that standard of care. So we have this three-pronged approach to expanding and sustaining the implementation of navigation globally. Through Beacon, we support high-quality patient navigation program development and implementation. You'll hear about that from Andre later today. Also, we are systematically integrating patient navigation into national cancer care systems through our Spark initiative. And this is early days for a very exciting effort. And thirdly, we are collectively addressing the common global challenges to navigation, recognition, quality of delivery, and sustainability through our Global Alliance for Cancer Patient Navigation. And each of these areas, each of these programs works across the areas you see on the slide there, again, to support that expansion of navigation. Next slide, please. And I want to briefly talk about our Global Alliance for Cancer Patient Navigation. So, even though there's a lot of interest and effort to introduce navigation into cancer care systems. There are common challenges that many of our partners are facing around the world and that we ourselves have faced in the US. So we formed the Global Alliance for Cancer Patient Navigation in 2025 to bring together diverse global partners from all parts of the world with experience or expertise in some aspect of navigation to really identify those common challenges and address the fragmented and inconsistent delivery of navigation in cancer care. So we're now working with a variety of stakeholders in implementation science, capacity development, advocacy, policy making, et cetera. And again, convening them for a bigger purpose. So we will soon publish our patient navigation call to action in the journal Cancer. And we have working groups that are developing a variety of meaningful projects. For instance, we'll soon be conducting an international Delphi study to update the guiding principles for navigation that reflect the updated practice and priorities around the world. And even though we're not actively expanding the membership of the Alliance at that time, I encourage you to check out, learn more about the Alliance and follow our developments on our website, as well as our patient navigation room on UICC Connect and our ACS Global page on LinkedIn. And I've included the link here to our first annual meeting held in June, where the detailed work of each of the groups is outlined. Thank you for your time, and I look forward to the conversation in a short while.
So much, Christy. And for those in the audience, please do remember to put your questions for any of the presenters into the Q&A box. And we've also added a question to the chat box for you all to share your experiences with each other. And please feel free to respond to this and any other questions as we continue our presentations. Next, I'm delighted that we'll hear from Mridu Gupta. Mridu has more than 30 years experience of driving social impact. As co-founder and CEO of Cancer Awareness Prevention and Early Detection Trust, or CAPED in India, she has advanced cervical cancer prevention by driving awareness, education, strategic screening programs, early detection initiatives, and patient navigation models. So over to you, Mridu.
Thank you, Alexander. Hi, everybody. So I'm Mridu Gupta from India, and I lead CAPED, Cancer Awareness Prevention and Early Detection Trust. We have been around for 12 years, and we're an implementation organization. So most of our information is to do with ground realities, and that's how we've built it up. So Sarah, if I can have the first slide. So if you look at this is the work that we've done across India. And all of our stats have come about organically. We started with saying that the problem with India, our problem statement was lack of awareness. And that's from where we started. And we realized awareness wasn't enough if we couldn't give people, if they had nowhere to go for screening. And then we started with screening. And once we started with screening, building the primary health centers for screening, we realized they have, what would we do after screening? They needed to go in for treatment. And that's when our patient navigation program started, because we had to get women to care. In India, public health is free of cost. However, it is completely fragmented across the journey. And the largest burden, of course, is lack of awareness. Even though screening is available at the primary health centers, women are not aware of it. So the journey for us starts from creating awareness and bringing women to screening, and then from screening, getting them to confirmatory diagnosis and then treatment. So that is the journey of our patient navigation. Next slide, please. Now, we do call this the patient navigation journey. However, the first bit of it, which is to bring women to screening, that's called mobilization. So that's where we bring all women over the age of 30 have to get the awareness to come in for screening, population-based screening. Earlier, this entire program was being done by CAPED, but now that we work at Health System Strengthening, we are identifying the right people at the right points to build this capacity into the health system. So the first bit, we do the awareness, and to bring women to screening, we do it with community health workers. The Ashas in India, they are trained to move into community. In any case, they go door to door. So what is it that they have to say? What is the requirement of the government? What is the age group they're looking at? All of that is part of mobilization. And then women come to the primary health center to be screened. And post-screening, we do counseling pre and post screening. The ASHA worker does the pre-screening counseling. The community health officer who does the screening, she does the post-screening counseling to get women to care. After which we immediately do follow-up calls for within 24 or 48 hours. And then on day 7, on day 15, on day 30th, we do follow-up calls to get women to come for their diagnosis and their follow-up for treatment if they are diagnosed. So this entire thing, whether it is assistance with appointments, documents, transportation, hospital visits, all of that is coordinated under the patient navigation system. If we can have the next slide. Now, this is actually an internal slide. We use it as a review for us at the end of the year to understand what we've done, what's worked, what hasn't worked, how do we strategize. But if you look at it, out of 87,470 beneficiaries, we had 7,350 abnormal cases, which means that they were screened positive. And out of which 5,624 disagreed to come forward for further diagnosis. Even though they had a positive report in their hands, they didn't come forward. This is where the barriers come into place, and this is like a dark hole for us still. We have tried multiple strategies. I will also share with you what we have done to solve this, but this is a gap. All the barriers that we talk about to care, that all of them play a role here. The fear, the insecurity, all financial, all the other burdens come here, and these women do not come forward. Out of the women who have agreed to come, some of them come for the first round and then drop off. They don't come forward. Some, of course, are screened. They may have been positive at the time of screening, but then their further diagnosis, they are cleared, and those are the halted cases. If you look at the lives saved, these are 839 women who were caught early and who were treated in time. Those are the ones that we have saved. 121 were caught despite doing a population-based screening. They were caught late. They are still in treatment. And we have 662 who still sit on the fence. They don't know whether they want to come in they want to go forward for treatment, or they do not want to take it forward. Again, that fear and all of the others that play a role in this. This is our internal slide about how the patient navigation program is going currently and what are the barriers that come in the way for it. So the next slide. If I zoom out and I look at our patient navigation program, we have the structure in place. It's functional, it's practical. What really is missing is probably the emotional support that is needed for women. We could have counseling that is pre and post screening, but fear doesn't work that way. Fear comes anytime in the continuum of care, and we do not have a 24/7 helpline. We do not have anybody to support the women continuously. And as an organization, and even now that we are handing it over to the government, there is this gap where she does not have constant support whenever she needs it. And I feel that's one of the reasons when we observe the journey that women fall off the path, that the emotional support. And we were speaking to an onco-psychologist in Russia, and they said that Russia has a program where cancer survivors are buddies. They have a buddy program where cancer survivors support the women who come in for screening from the time of screening. And I really think that's a lovely idea that we could experiment with this year. But so far, this is what we do. For fear and stigma, we realize that exists, and we have evidence-based solutions for that. We have the communication, we have the counseling, we work with the government at multiple levels for that counseling. ASHA workers, ASHAs are our community health workers. They do the follow-ups. We have trained CSO representatives in most of the states that we work in so that they can take it forward on the ground. And we have survivor-led support groups that are local. For family and social barriers, when we go into the villages, even when the community health workers go, she speaks to the entire family. So we have a men-to-end cervical cancer program where all the men are also informed on what needs to be done. The pre and the post-screening counseling. Community mobilization, all of that addresses these family, answers questions that the men may have or children may have or the entire family structure. For economic and practical barriers, I told you that the government has made for healthcare is free in India. But even so, we've tried to get free transportation, public transportation for women who have a cancer card. We are trying to build that flexible scheduling for them, not very rigid. All of that we have already done. However, like you've seen, so many women fall off the grid, despite addressing these barriers and knowing that they exist. And of course, the entire data system in India is fragmented and in pieces. And we are trying to connect the dots through a patient tracking pathway that we are building with the Indian Institute of Technology, Delhi. And that will track the woman across the entire pathway of care and identify where she's missing, where she doesn't turn up. And we are looking at trying to build that into the current government system so that we can support her wherever that support is needed. So these are some of the barriers and some of the solutions we have. Despite all of this, we still lose a lot of women. So anybody here who has solutions for something like that, we'd be so happy to hear from you. This is just the journey that we have on the field, what we do with our PNP, our patient navigation program, and how we build into it. So largely, this is the program we have in India. It's just an organic program that answers the need that the women have on the ground, and the fact that we have been able to complete care for about 800 odd women does say that it is successful, and it can be, though we have a long way to go on this. Thank you.
Thank you so much. So much work being done, so much impressive work, and really interesting to hear of Caped's experience navigating women from cervical cancer screening and onto treatment when needed. Next, I'd like to welcome Rabba Salah of the Bahia Foundation in Egypt. In many places, formal cancer patient navigation programs are new and emerging. So we've invited Radwa to share about their breast cancer patient navigation program that we think has many lessons that can be shared across other women's cancer patient navigation programs. Radwa is a pharmacist and healthcare program leader at the Bahia Foundation and medical liaison for their international team. He's currently a senior program development professional at the Bahia Hospitals and Centre, and she brings extensive experience in patient education, care navigation, and healthcare program design. Rabba.
Can you hear me? Thank you, Alexander, for your introduction and for your insightful thoughts. So let's begin our journey. We are talk about our goals for navigation. I'm from Bahia Foundation for Early Detection and for breast cancer, as Alexander said. But we have our navigation in hospital. We didn't have this community navigation in fragmented system. We have our navigation in the hospitals, and we have this model of one-stop clinic, all services done at the same place. So the goal that we build the navigation for that to raise the awareness and education about breast cancer for the patients and provide a focal point contact for patients that could meet all and have the access for the navigator if the patient have any inquiry, any information she want to know, any resources to be linked. And the third goal, we stick to that we are a people-centered model. So to be a people-centered model, you should understand the patient individual needs and the challenges that by addressing the barriers to care and linking the patients to the resources. And number four, that will provide psychological support for the patient to cope with the emotional and psychological changes through all the treatment care. Thank you. Next slide, please. Next slide. So, next slide. This is not the next slide. Slide number 4. So that's it. This is a simple scenario. That's what happened when the patient diagnosed with cancer. Patient have two scenarios. If she keep fighting and keep being on track for the treatment, or the patient will drop out of the treatment because she have a barriers to care. So what we do to eliminate these barriers. This is the rule of the navigation. So how to shape this and how to reshape your team. To achieve this goal, you should first reshape your team and know each one's responsibility. Then build a structured program of integrated services. Navigation doesn't build a new system in the hospital, it's integrated in the hospital own system. So you should know the gaps that find in your institution and begin to bridge this gap. This is the role of navigation. Then initiate the projects that ease the patient journey or ease the patient, overcome the patient's barriers. After all of this, you should measure the impact and monitor your progress to maintain the sustainability of your program. Next slide. So this is the 4 pillars that we adhere to Bahia Patient Navigation Program. The psychological, the social services, the first, and resource navigator. We call the resource navigator the one person to go because he have the all resources, the medical resources, the social resources that patient need, and the clinical navigators that the clinical navigator provide one-to-one education and provide education session for the patients and correct any misbeliefs for the patients. As well, the physical navigator. Physical navigator is our dynamo. Someone is very energetic to solve any barriers, physical barriers that found internally in the hospital. Next slide. So this is a recap of what we said. We have a patient. The patient have 2 options. If the patient keep fighting or the patient drop out of the treatment because barriers. And this is the list of the barriers that we customize based on Bahia and our culture in Egypt, like communication barrier, education, psychological or operational barriers, etc. Next slide. So why we address this barrier? Our role or our main role that we address this barrier to reduce and overcome the patient barriers and adhere the patient to the treatment journey. This is aligning with the GBCI Global Breast Cancer Initiative Pillar 3 that 80% of the patients undergo full courses of multimodality treatment. So how we achieve this? We achieve this through those projects. Patients may have educational barriers or health illiteracy, so we provide educational projects like we have our booklet, frequently asked question booklet, regarding the most frequent question that the patient asked for. And also we have our education session that we held for the patient. It held monthly for the patients. The materials and the smart education are provided for one-to-one education for the patients. Otherwise, if the patient doesn't have this kind of barriers, you might have the operational barriers. So we have this operational projects like no-show project. No-show is responsible to bring back the patients who missing their appointments. And the patient flow is such a project that we provide for the patient to facilitate their movement and workflow in the hospital. The shadowing, I consider this is the validation of our work. The shadowing considered to shadow each service or each step that the patient take all over the hospital or all over hair treatment. So numbers of dashboards may be correct, but you should validate this. And we take this from the SES toolkit to be our guidance. Also, we have the development to sustain our program, such a HIS module. This is for documentation, technology for documentation, our data, and the volunteering in clinical navigation and non-clinical navigation. Soon, Bahia have opened her operations and inpatient services. So we try to integrate the navigation services into this new facilities that have provided by Bahia. And for the empowerment, we are working for hospital empowerment, like publications for patient navigation. And we are working for a podcast for patient stories that may be inspiring for another patients. Next slide. This is kind of a monthly patient education session that we held. The monthly patient education session that we held, including all the departments, the surgery, the radiotherapy, physiotherapy, all things, and it's provided by physician and nursing for the patient to, if they have any clinical question, they have such a lecture to question anything from the physician or the nurse. Next slide. This is something interactive that we have developed this year. That's such a game about myths and truth, about many misbeliefs that the patient think. Like we have some misbeliefs of patients who think that going for surgery might spread the cancer all over her body, but this is not true. So we began to have this game with the patient. Do you think that surgery could spread the cancer? She brings the green card because she thinks yes, and our clinical navigator began to correct this misbeliefs. That's to provide the interaction and also to have the exposure for many patients to know about the navigation and clinical navigator, and they always open to them to ask any question. Next slide. So this is the slide. So we now build the patient navigation, how to sustain a patient navigation program. First thing, patient navigation depends mainly on volunteering at Bahia. So we have three types of volunteering: the non-clinical and clinical, and patients and caregiver people with lived experience. We have a structured volunteering program for all of this, and began to have the training and shadowing, monitoring this volunteer. And after 1 week, the volunteer bring to the real ground and being deal with the patients. Second thing, the integration of our projects with our organization operational flow. As I have said, you are not building a new system. You are integrated in your own system, so you are not standing alone. You should be integrated with your own organizational flow to know how to bridge the gaps. And this is the role of navigation, connecting all of these departments and bridging the gaps to overcome any barriers to care for the patients. Regular assessment and training. This is a main core of patient navigation because the knowledge is power. So if your navigator is missing some info, this doesn't work because they are the main contact for the patient to being asked. So this is important to have this regular training and assessment. And we have this structured training curriculum. We began to have 3 months training, and then 6 months training, and then 1 year. Each one have a pre-assessment and post-assessment. The burnout session, we know that navigator have this negative burden because they listen too much for patients complain. So we held the regular burnout sessions each month. And this burnout session, we began to have a theater movie for navigators, celebrate something with them. And last but not least, HIS information system. It's a digital tool for documentation and how to measure and control your insights. That's to sustain and develop your program. And all of this, you customize it as we are at Bahia, customize this for our sustainability. If you are building your new program or you have own program, you should customize this based on your culture and based on your insights and the gaps that your organization need. Next slide. Thank you for listening. This was a graduation of our navigators after the first wave of training. And they have their own projects, graduation projects. That's all for today. Thank you for listening, and thank you, DCS, for this opportunity.
Thank you so much, Rabba. That's a really lovely note to finish on as well. Lots of hope there. Next, we're going to hear from Dr. Ishak Lawal of End Cervical Cancer Nigeria. Dr. Lawal is a consultant obstetrician and gynecologist at the Federal Medical Center, Benin Kebbi, Nigeria. He's a recognized leader in cervical cancer prevention and treatment in low resource settings and has been instrumental in expanding access to evidence-based cervical cancer care while addressing the challenges of limited healthcare resources and infrastructure. Welcome, Dr. Lawal. Over to you.
Yeah, good morning, good afternoon, good evening, everyone. It's a pleasure. Thank you for that kind introduction. Next slide. So I will be talking about expanding patient navigation in Nigeria from the lessons from the system for navigating cervical cancer for treatment. So please, next slide. So that's where I'll be talking. The objective is for me to use our experience creating that system for navigating cervical cancer for treatment to learn how to expand cervical cancer and patient navigation in Nigeria. But I just want to use this slide to set some template in terms of the fact that what was even that genesis, what was that stimulating factor that made us to even think about system for navigating cervical cancer for treatment? And it relates to what Christy mentioned in her opening remark about the fact that navigating the continuum of cancer care can be very challenging, and more so for cervical cancer. And if you look at this on the right-hand side, where we have all the components of things required for cervical cancer screening. When we talk about screening, we just look at that process on its own when it just has to do with the application of HPV testing, or if you're using the pap smear application of the test result on the woman. But screening on its own does not save life. We keep saying that because it is the treatment of the screen detected that saves life. Hence, we discovered that there is a lot of screening activities happening in Nigeria, and few women are able to go through the continuum of care. So it then becomes that it looks like the screening is not saving life for them because they're not able to achieve treatment. Now, when the WHO now talked about cervical cancer elimination targets, that was the genesis of End Cervical Cancer Nigeria initiative. Therefore, everything we do is along the cervical cancer elimination target. And that was why when we now started observing that women are not having that continuum of care, we then started this concept of cervical cancer, navigating cervical cancer for treatment. Sorry. Then this other concept where we talked about late presentation versus late intervention. We also noticed that most of the patients that we work with present to hospitals like 2, 3, 4 times, and like 6 months interval before they eventually receive treatment. So these two factors were the stimulating factors that made us to go into this patient navigation. Please, next slide. So when we've been thinking about how to support patients in terms of ensuring that the screening leads to impact, that the screening will save life by way of ensuring that they get treated, and to ensure that the patient that present early eventually have early intervention. Because we discover that sometimes when they present the late intervention because of challenges, eventually they still go to advanced stages. So the opportunity presented in 2025 when ILERA Community Health Initiative approached us in March that they have screened some women during the World Cancer Day celebration of that year in February. And by March, the women screen positive cases were not able to receive treatment. So they approached us, and then together, we agreed that the 5 screen positive cases that they detected in February, we worked with the University of Abuja Teaching Hospital, Gwagwalada, and we navigated those 5. So we used that opportunity to learn how to navigate pre-invasive lesions. Because if you look at the WHO cervical cancer elimination targets, the 90% treatment target has 2 prongs: treatment of pre-invasive lesion and treatment of invasive lesion. So we use our relationship with ILERA to understand the continuum of care needed for the pre-invasive lesion, and we use a navigation of a patient. I hope she's on this call now, Mercy Moses. She's a 26-year-old. She was 23 when she was diagnosed with stage 2B cervical cancer. And it took us 3 years to navigate her to treatment. And so we use our own case studies to understand the continuum, the challenges for treatment of invasive lesion. And when we started, we didn't really understand. Please, next slide. So when we started, we didn't really understand patient navigation. So when we saw that we had to do this, we had to add the patient navigation into what we're doing, and we want to do it well, we then had to join the Beacon community. And from the Beacon community, we then begin to understand what patient navigation really meant. And we also understand that almost all the CSOs in the country are involved in one form of patient navigation or the other. So, I mean, I'm not speaking for Beacon community, but I will really encourage CSOs and individuals on this platform that to think through what they are doing and maybe join the Beacon community or use the resources in the Beacon community to have a better understanding so that they can refine what they are doing and have it formalized. But what did we, please, next slide. So we learned from the Beacon community that next slide, that there are three forms of patient navigation. So for us, for the pre-invasive lesion, we are using the physical navigation. No, not next, please move backward. For the pre-invasive lesion, we are using the physical navigation, while for the, please, slide 5, one slide backward. Thank you. So while yes, thank you. So for the pre-invasive lesion, we're doing the physical and clinical navigation, while for the invasive lesion, we are doing the three. We added the resource navigation because we discovered that resource challenges is one of the major challenge for access to care for invasive lesion because it's very expensive. Please, next slide. So, and that's also what brought us to the concept of resource stratified management of cervical cancer. Please, next slide. Yes, good. You can here we talk about the resource stratification management of cervical cancer because we discovered that we cannot, based on our experience, you cannot use one experience to cater for all of them. And like the cervical cancer management using radiotherapy can be very expensive. So we're also beginning to look at use of chemotherapy. So based on what we have achieved with the spatial navigation experience, we were able to ensure that the pre-invasive lesion patients at the University of Abuja Teaching Hospital, Gwagwalada, based on, have one single visit. Because before then, patients might have to visit 3, 4, 5 times after they have a screen positive result. But with the patient navigation we are doing there, with one visit using phone call, we're able to do that. Then when we started the invasive lesion navigation, we started using a Google form online. And the challenges we discover is that patient navigation can be capital intensive. It's a lot of time out of emotion, we're doing it, but we need to start looking at how we can explore, like in our next step now, we're looking at how we can explore the Spark project in Nigeria to expand the patient navigation program we're doing. And we are also, based on our experience, we are looking at the JOC study, which we talk about journey to cervical cancer treatment study to better understand all the challenges patients are going through and be able to improve their care. Please, next slide. I think the next slide will just be the thank you slide, which again, I just want to is to say thank you for this opportunity and also to emphasize that anywhere we have our presentation, we always use the transport system as a way to show that the journey to cervical cancer elimination can be achieved through various means of transportation. And here, I'm here on the ambulance, quote unquote, that brought a patient to the hospital. So it's not all the time that we might have to use the best means of transportation, but most important thing is use what you have to try to achieve the goal. Thank you.
Thank you so much, Dr. Llewellyn, and a really clear rallying cry to finish the presentation on there. Our final presenter today is Andrei Chibisov, and Andrei is a program manager for global patient support at the American Cancer Society, where he leads initiatives that strengthen patient navigation, improve access to cancer care, and advance patient-centered care models worldwide. Over to you, Andrei.
Thank you, Alex. It's really nice to see all the questions that are coming through the chat, through the Q&A, and my presentation will focus on our Beacon Capacity Development Initiative to help build effective and locally responsive patient navigation programs. We draw upon the early organizational experience supporting patient navigation programs in two countries, Kenya and Uganda. Having analyzed that experience, we launched Beacon in February 2022 with just 10 organizations in 8 countries as a pilot. Today, the program continues with 58 organizations in 36 countries, and we are growing every month. The Beacon Initiative supports health institutions and cancer organizations in low and middle income countries and other relevant settings focused on addressing health disparities in cancer care. We help design, implement, and sustain cancer navigation programs and support integration of patient navigation into cancer control planning and cancer care delivery. Beacon accomplishes this by providing free resources through the online platform that includes the Global Oncology Navigation Toolkit, which is a comprehensive resource featuring hundreds of online learning modules, downloadable materials, which support program development, and the Global Oncology Navigation Community of Practice, which is a network of practitioners worldwide to connect, share experiences, and learn through virtual events and other collaborative opportunities. Additionally, Beacon participants benefit from resources like periodic virtual events and peer resources library, which we are building right now. The initiative empowers organizations to build capacity, foster meaningful connections, and advance patient navigation in the global context. Next slide, please. So let's look at the first component of the Beacon Initiative. When we set out to build upon our early successes in Kenya and Uganda, we met with a variety of stakeholders to help inform that we would create the Beacon Toolkit. The framework for this toolkit you can see right now on the screen. We have imagined users ranging from almost no knowledge about patient navigation to those who are implementing their programs or are seeking to improve their quality. The toolkit, as a result, is divided into 3 main phases. Lay the foundations, which provides the basic cancer care information to anyone. Design and launch your program, which really helps to do what the phase is entitled to. And implement and strengthen your program, which is phase 3. Each phase is divided into 3 sections, which in turn consist of a lot of activities. We have resources to download online, and you can work with those downloaded resources offline. The image at the right is a look at the e-learning platform, where resources are introduced in downloadable format. The toolkit does not provide answers to all questions. Instead, it acknowledges that no 2 health systems or patient populations are the same, and it provides adaptable tools for practical and step-by-step resources to tailor programs to local needs. As noted earlier, our toolkit is supported by a growing global community of practice, whereby patient navigation practitioners gather regularly to learn from and share with others facing similar challenges in their settings. Next slide, please. Here you can have see some examples of the resources, and there are three QR codes. So if you hover your phones on these codes, you can download the resources just to sample them. The resources that you can download include guides, templates, samples, examples, handouts, and various program tools in Word and Excel that really help you support your program implementation. Um, Finally, we can go to the next slide. The toolkit lives inside the online community platform, where we connect our members to one another, share various announcements, including the virtual events. Next slide, please. On this map, you can see the current reach of our program. So you can look up your country and see whether or not your country is part of the Beacon initiative. If not, we invite you to apply, and perhaps you can become the first organization in your country to join Beacon. And my final slide, please. If you're thinking where to start and how to improve your existing patient navigation program, we encourage you to review the Beacon materials more in detail. So you can follow the links on the screen to watch the videos, visit our Beacon webpage, and you can reach out to us at the email shown here. Don't hesitate to reach out, and we'll get you started with the Beacon community. Thank you.
Thank you so much, Andre. I'd now like to welcome back all of our presenters for a panel question and answer session. So for those in the audience, please do continue adding your questions to the Q&A box. We'll see how many we can get through live here today. But we'll begin with a few of the questions that you actually shared when you registered for today. And we'll start with our most common questions. And perhaps unsurprisingly, the most common question was around resource mobilization, really around, how do you support or fund patient navigation programs, whether they're in communities or treatment centers? And Radwa, I wonder if I could come to you first. How have you managed to secure funding and institutional support for patient navigation programs?
So we are at Bahia an NGO project. We first to build our patient navigation, we have a grant from the ACS to build our patient navigation. And for the sustainability, we have this funding from our foundation. How to sustain this funding from our organization? Based on our outcome, we began to persuade the management of the importance of patient navigation. So this is the main core that we depend on funding the patient navigation. The first we began with the grant of the ACS, and now we continue with the funding from Bahia Foundation based on the outcomes of the navigation. And also Bahia Foundation have finding that a navigation make a difference in patients' lives. So this is the sustainability that we are working now.
Great, thank you. And maybe I can move to you, Dr. Lawal. You're in an earlier stage of trying to grow patient navigation. What strategies are you using to fund or support this work?
Yeah, thank you very much for that question. Funding has been an issue, and we've been doing it emotionally. And just recently, when we're trying to expand, I went to the roundtable patient navigation something, and I discovered that they were talking about funding, and I am beginning to get the idea that we might, looking at the environment in Nigeria, we might begin to get patients to pay for patient navigation services if they understand the importance. And this idea came from the fact that when we brought out a Google form for patients that are looking for that having challenge to access care, cervical cancer care, to reach out to us, and then we call them. A lot of times, what they are looking for is the information, and we are then beginning to look at a possibility of charging for that services, but it's just still we don't have a funding clear funding pattern yet. But the other option is also we look at goodwill, just like NGOs are using goodwill donations to fund the NGO activities. We also want to make patient navigation central of our activities and also get donation and goodwill to fund it just as we are funding the screening. Like when we discuss to some of our organizations that we work with, we tell them that if you screen one, if you go for screening outreach and you have screened a set of people, you don't initiate another screening outreach except you ensure that those you screen get treatment. Thank you.
Thank you. No, I really appreciate that. And I think it shows the importance of thinking really broadly about what the opportunities are to fund this work. I wonder if I could just finally on this question come to Mridu and just wonder what communication strategies or arguments you found have resonated most with decision makers or funders to gain their support, because it is a novel approach in many situations. How do we convince people that it's an important one?
So, thank you for that, Alexandra. In the beginning, it was a little difficult convincing donors as well as convincing the government that this needs to be done. But in the last few years, the first few years, we survived on our own. We raised CSR funds to do this and to show that it works. So the proof of concept was done through CSR funds. But now that we do have evidence, we know that it works, we know that we've saved lives. Every time we go and speak to the government, that's all we have to tell them. The fact that the referral pathway in India is fragmented and we're losing women. They say out of 1,000 women screened, only 10 will finish the journey, will adhere to treatment and actually finish the journey. These are government data, right? So they understand that there is a gap. Everyone's looking for solutions. So this is a possible solution. And now what we do with governments is try and integrate it into the government system. So we have a train the trainer model where we first train the community health workers to get women to the screening. And then we train the HCPs, the government healthcare providers, to be able to consult them and get them onto the referral pathway. So that's the only way that it is sustainable for us now. And our proof of concept, this entire journey that we have mapped, is our communication tool. I mean, that's what we use to tell them that it works and why it's necessary. So that's, I guess in the beginning, you have to do it yourself to be able to, have some evidence to convince people. And then, of course, now it's
Fantastic. Yeah.
part of policy and discussion at the central government level.
Right. So I think that speaks to the power of data. Not just for ourselves to be able to tell that story and to change minds. Just in the interest of time, I think we'll move on to the next question. And another question that's been very common, a common theme, is around something you've just touched on, failing to retain women for diagnostic follow-up after a private screening, after a positive screening, sorry. So, Mridu, if I could stay with you, what strategies have worked for CAPED in addressing the challenge of keeping women connected to care after screening or diagnosis?
So currently, Alexandra, it's a very manpower intensive one. It's like speaking to her, visiting the homes, making community health workers visit with her. And because nobody has the bandwidth to go on with it over a long period of time, we still have women falling through. So if you look at our data, we've managed to only take 23% women through the journey of treatment. I mean, WHO says 90% women should have access to treatment. We've been able to navigate barely 23 to 30% of women. And that's because at that point of time, some women need more time. Some of them come on board quickly enough. They understand what needs to be done. If you can speak to her family, ensure that she has that family support and she has community support, she's willing to come on board. But sometimes people take longer and we do lose those women across that journey. But it does require one-on-one connect. It requires explaining to her, being available for the entire thought process that she has. You're changing a mindset. You're trying to tell her that you're perfectly okay, you have no symptoms, but you have an infection that we want to check, right? So if the woman has symptoms, we've realized she comes very quickly onto care. She has those symptoms, so there's something that triggers her. And of course, if it's advanced and there is pain and there's urgency, she comes very quickly. But when you catch them in early stages, very difficult to convince them to come on board. It requires a long and very patient journey about visiting, getting the family to push, getting the elders in the family to come on board and convince her to come. All of that. All of that is
So
part of
much.
it.
Thank you. And again, in the interest of time, I'm going to keep us moving so we can get through as much as possible. And Christy, I'd like to come to you next. Um, from an implementation research perspective, how is the effectiveness of the PN program measured or monitored? Is it easy to determine a baseline and how is that done?
Well, it's a great question. And obviously, as we talk about the importance of making the case, we know that data is super important. I'll say that for one, you have to think about wherever you're putting navigation, in what context is it working. So in the case of a health facility, what data management systems already exist? If it's a paper-based system, that's going to be a lot harder than, let's say, an EMR. But even an EMR, integrating navigation might be challenging. So I think first and foremost is deciding what is it that we are trying to achieve with our program. And I was just trying to write a response to Ferry, and I will finish it. But being super clear about what you're trying to achieve and then what are going to be those measures that show it. So for instance, in Kenya, it was really important in the first program that we supported that they reduce the missed appointments and delays in treatment. And so we were able to devise, a system that could look at that. But that was a very intensive effort. One of the first things I would say is focus on those outputs that really demonstrate that you're delivering the services that you set out to achieve and that those services are matching to the barriers that hopefully you identified through some type of a navigation needs, or excuse me, a patient needs assessment. Because that is where you can just at a very basic level say, we're doing what we said we're going to do. And then how you will measure the true outcomes, I'll just say that it does take a lot of resources. And even, in 30 years of the United States, it's not been the easiest thing to make that happen. But that's also why part of the alliance is really trying to coalesce all of the data that's already been collected. What do we know about it? And how has it even been evolving over the last 7 years since there was a landscape analysis done to then be able to use that data to articulate navigation does make a difference. And therefore, let's focus on how do we ensure that we're building it into our systems and making those investments and that's the next kind of frontier is that cost benefit analysis of navigation that will then make it for the policymakers the case for why if you do this, yes, it will cost you here, but here's what you're going to save on the other side. So that
Yeah.
is something that the Alliance is thinking about because everything you're talking about is something that every program is going to face. And I'll just say we do have resources in the toolkit that help you, again, look at your system and build an M&E system that can work with what you're trying to achieve and what you have to work with in your setting. So we encourage everyone to take a look at that, including some possible indicators.
Brilliant, Chris. Yeah, that really useful practical tool there. I'm going to move on again. We've had lots of questions around challenges to do with starting a program and sustaining it. So, Andre, if I could come to you, if for organizations just beginning this work or thinking about beginning, what's the first one or two steps someone interested in starting or growing a navigation program should take?
Thank you, Alex. Great question. I think the first step is really to have a common understanding of what you're trying to achieve, what you're trying to build, what is navigation. Because if you ask 5, 10 organizations, what is navigation? A lot of them will tell, "Oh, we navigate patients." But then once you start like asking more closely, turns out that the organizations provide patient support services, which is not like individualized assistance like patient navigation. Then there are certain elements that once you have reviewed the information about what navigation is and is not, which again, I I'm inviting you all to join the Beacon community because we have a very eloquently written toolkit with all of this information. The next step is to look at the services available in the clinical facility. How do patients get to the clinical facility? Have some exercises that will allow you to have some needs assessments. Where are the barriers where patients are falling through the cracks? Is it long lines? Is it inability to come to appointments? Is it the elders that are preventing patient from arriving into diagnosis and treatment? Is it financial barriers? So navigation is breaking the barriers down, and so that is the next step. And then, of course, think about what is realistic to do in your given your funding level, given the level of your partnerships. Are you partnering with an NGO if you're a healthcare facility? Then what are the comparative advantages of the two organizations partnering together and kind of starting to chip away at those barriers. And again, keeping the monitoring in mind, keeping sustainability in mind. We don't want to start grand only to have to wrap the program down in a year or two. We really need to think about how we are engaging the donors in our information sharing. Do we share the results, even the early results of the program with them? How do we keep them informed so that later we could have this ask? Thinking through not just the patient journeys through the program, but also the donor information journey through your program. All of these are very important steps.
Thank
And of
you.
course, we shared the toolkit links, the links to the community. Please reach out if you would like to join the Beacon community.
Brilliant. Yeah, just a reminder there that the resources are all available through the chat and will be sent. They'll be through the recording. We'll be sending out afterwards as well. Drawing to our live questions, a really nice question around the skills for patient navigation. And this is open to any of our panel. How can nursing students begin developing the skills needed to support patient navigation and improve patient outcomes? Anyone, any thoughts from any of our panel?
So nursing students?
Yeah.
Yeah, I'll just say, I didn't talk a lot about our Spark initiative, but that is one where we are working in 3 specific countries to try to build a navigation system, Kenya, Indonesia, Nigeria, and we're also going to hopefully learn from that and share that with our broader community. But we've convened a technical working group that's thinking about if navigation was a reality in 5 to 10 years, what are all the building blocks that we need to do? So that is kind of one of the discussions is what does a navigation curriculum look like? Where does it get introduced? So that again, we're building not just the skills of individual navigators, but that mindset and that systems approach to thinking about it. But if we're talking about clinical navigation versus, the delivery of nursing care, there's all kinds of resources out there. And what is important across any of this is delineating the roles that already exist and ensuring that the navigators are adding value versus overstepping roles. And so, but, we do have a very robust field of clinical navigation in the US because we recognize that nurses have a specific role to do, and even they don't have the kind of time to provide that accompaniment support that's needed. So I'll just say there's lots of opportunities, but that really sits, at a higher level than any one program. That will sit with government thinking about, okay, how and where do we want to integrate navigation and what's going to give us the biggest bang for buck if we build a system for it.
Thank you very much. That's really useful. I'm going to throw out one more question and then we'll begin to wrap this up just purely because of time. But has anyone thought about how we can overcome the challenge of trusting in traditional healers or faith leaders in patient navigation? Is that something that anyone's come across? involving different members of the community, including from those kind of different backgrounds. Any one of our panel offer some thoughts?
Yeah, I mean, the thing about patient navigation, I mean, when we were in the breakout session, all the three countries show that the patient navigation is still starting. So the thing, because it's still starting, many people, many of the stakeholders still don't understand it. It's very clear from my experience that by the time stakeholders begin, which include traditional leaders, religious leaders, by the time they understand the value the patient navigation is bringing to the continuum of care, everybody will key in. And so, what we need to do as stakeholders here now that have understood the importance is for us to begin to document and show that without patient navigation, our efforts are not linked. Our effort is not improving care. And that with patient navigation, our effort is improving care, then getting everybody to key into it and support it shouldn't be a problem. And in terms of like we have what we call North-led cervical cancer screening project. And from what Andrew said, of course, we were part of those people that were supporting patients, and we were mixing up supporting patients and patient navigation. So if all we as stakeholders need to, I mean, Beacon community is the only community. Apology, I'm not making advertisement for Beacon community, but they're the only community that I have seen and I have benefited. So for those that want to transit their support care for patients and should endeavor to get more knowledge about what patient navigation means, and then every other thing will be added. Thank you.
Thank you very much. Now, just to wrap up this section as we move to the end, I'm going to ask each of you very, very briefly, as quickly as you can, if I may, if you had one piece of advice to a country or an organization looking to strengthen patient navigation as part of cervical cancer elimination, what would it be? So one piece of advice as quickly as you can. Shall we start with Andre?
I would say listen to the needs of the kind of listen, keep in mind the local context because patient navigation is not a universal cookie cutter approach. There is no yes or no's here. It all depends on the context locally.
Great. Rabwa, if I could come to you next.
My advice is navigation is integral service in your system, so don't stand alone. Have an integration and a coordination between you and your management, leadership, and the other departments or the other stakeholders. And I want to say that, as Dr. Ishak said, the navigation may be a new concept, so people should understand first what the navigation and what the aiming of the navigation. So for achieving this integration, you should bring the mindset first and have this coordination integration between you and all the stakeholders of your organization.
Thank you. Christy, could I come to you next?
I'm going to give the advice I give to everybody in Beacon, which is, just as cancer patient or individuals facing cancer get overwhelmed by this journey, you've heard a lot of different options here, a lot of different programs. Don't get overwhelmed by the process of building a program. Start small. We have a lot of ways that you can. If you can't do these 5 things, can you do this one thing? And that will start building your program. It'll build your confidence. And in the end, you will create something that it makes a meaningful difference in the lives of the people that you're supporting. Stay positive, start small.
Thank you. Dr. Ishak?
Yeah, I mean, same thing is that first we need to keep emphasizing that screening does not save life. It's the treatment of screen positive that saves life. And we should then begin to document the number of screen positive that are not able to get treatment and use that as advocacy to ensure that, look, before we screen the next set, why not ensure that those that we are screened get treated so that we can then make impact? Thank you.
Thank you. And Mrudu, the last word to you.
Yes, my single advice is to listen. So listen deeply. Communities have their own solutions. So if you can listen to them well, connect the dots, you will be able to create your own program and it will be a successful program. So I really believe that's where you start listening.
Wonderful.
Thank you.
Thank you. Well, thank you. I'm sure everyone will join me in thanking our wonderful panel today for all that insight and expertise that they've shared. Thank you too to all our audience for staying with us, and great to see the amount of engagement in the chat and the really thoughtful questions you put to our presenters. While we have your attention, we would like to let you know about two open funding opportunities that you may wish to consider. The International Cancer Foundation is supporting locally led projects that address critical gaps in cancer care across the cancer continuum, and the deadline for the current cycle is September 1st. The second opportunity is from UICC, the Union for International Cancer Control. And if you're a UICC member, you can apply for an implementation research project grant focused on women's cancers. And the deadline is August the 31st. And we'll put the links into the chat box. And we'll also follow up with everyone who registered to share resources and the recording from this session.
And our next dialogue is in September, which is quickly approaching. On here, you can see our topic. We're going to highlight some interventions and stories from various countries, and I'll put in there the registration link for that. So please join us in September. We thank you so much for joining us today and look forward to hearing from you and seeing you on September 17th.